All right, thank you very much for the opportunity. I'm going to talk about some of the novel bariatric procedures in vogue these days. And the objective is to discuss the concept of functional restriction, which is quite different from the anatomical restriction, which we all know as a mechanism of weight loss after bariatric surgery. So what causes weight loss after bariatric surgery? As we all know, the first is the functional restriction. The mechanical restriction. And that mechanical restriction, when you're trying to reduce the size of the stomach, and when you reduce the size of the stomach, you feel full early, and that leads to decreased intake of calories. So the patient energy balance disturbs, less calories are going, and this is the way he loses weight. The second is malabsorption because of the decrease in the surface area through which the digestive nutrients are absorbed. And the most important for us then, which is the topic for today, is the hormonal changes that leads to functional restriction. We now know that the diabetes gets better before the weight loss happens. So why it happens? And when research has been done, it will show that the early delivery of nutrients to the ileum produces certain hormones which are incretins like GLP-1, and they are steady hormones like oxytocin and glycine and PYY. That basically decreases the motility of the stomach, and the patient feels full. So insulin also is released, and that insulin decreases the levels of the glucose and leads to better glucose homeostasis. So thinking based on that mechanism, the surgeons have now started thinking, why not to combine the concept of functional restriction and the mechanical restriction together to produce different novel procedures, which I'm going to talk about shortly. Then we all know that there is something with the production, the bile acids and the microbiome or the biota, which is present in the intestine, that can also play a role in either the weight gain or the weight loss, and still under consideration. Well, let's talk about the hormonal mechanism of weight loss. So due to the great work of Francesco Rubino, we know that there are two theories regarding the hormonal mechanism of weight loss and a better glucose homeostasis. The first one is the foregut theory, which has its outground when the food somehow there is basically bypassed from the proximal intestine, especially the duodenum. This food goes directly into the intestine, where the ileal cells, the L cells, produces the hormones, the GLP-1 and GIP, which are known basically incretins. And not only L cell produce GLP-1, but they also produces PYY, oxytocin, and glycine hormones. And they have an increased impact on this insulin. So GLP, the incretin, increases the production of insulin from the beta cells and leads to good glucose control. But at the same time, the PYY, oxytocin, and glycine hormones and GIP, they are basically produced and they release to at least satiety. And this is a typical intestine strategy. You get satiety because you feel full to the stomach, and that happens early. And the anatomical restriction is going to bring it. And the second one is you get satiety because of the release of, and this is very natural. We all feel full after, we don't want to eat after 1.5 hours of what we have eaten. So, and this is because of the release of the hormones from the distal ileum. Similarly, there are other mechanisms like leptin produced by adipocytes, and leptin is an ideal hormone. Unfortunately, it's very difficult to formulate leptin. This is released by the adipocytes, and it has a direct impact on the insulin. And insulin, we all know, is, although it controls the blood glucose, but we all know that it inhibits the lipolysis. And the lipolysis, when it inhibits it, it is a great hormone that produces deposits of fat. So this leptin and insulin has a direct relationship. And thirdly, this ghrelin hormone, which is produced mostly from the stomach. It is the hormone which produces hunger. So somehow when we resect part of the stomach, especially in sleepless type, there is a decreased production of the hormone of ghrelin that leads to less hunger. So our appetite is suppressed, and simultaneously we feel full. And these are the mechanisms which are responsible for functional restriction and also better glucose homeostasis. So based on these, now surgeons started thinking that not only we do sleep gastrectomy and produce anatomical restriction, but we need to do these bypasses so that the food goes early into the distal ileum, and these steady hormones are released, and that leads to functional restriction. And these are good for those who are not very much obese. So these new procedures are good for patients who are not very much obese, but they have uncontrolled diabetes. And because of the better release of incretins, these procedures are now investigated for uh, diabetic patients who are less obese. So there are 6 variants I'm going to talk about. Uh, the 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 3 upper ones are now formally being done more frequently and getting good results. The SEDI, a great weight loss procedure after the weight regain, so it's still reserved for uh, regional bariatric procedures. The new one is a SASI procedure, and then is a duodenal bipartition. And these are the one I'm going to talk about and will touch about. In everything, there is an enteral bypass, and we're trying to basically either exclude the foregut, or we're trying to basically deliver the food to the distal ileum so that these hormones can be released and use as functional section. So this is a SADI procedure. This is now already established. This is replaced the classical duodenal switch operation. And the advantage is that there is only single anastomosis, and there is a common channel of about 250 centimeter. So duodenal switch is 100 centimeters at a common channel of 250 centimeter. And that is basically produces less malabsorption. So SADI is a good weight loss procedure, both in the terms of metabolic as a weight loss. The next is a duodenal, this is called SASI procedure. Uh, the disadvantage of this, the advantage is that it produces both anatomic and functional restriction and better glucose homeostasis. The disadvantage is there are chances of reflux. So there's a huge chance of reflux. That's why it's not that popular. Then there is a jejunostomy or a ciliegectomy with jejunostomy. Again, the food is going directly into the ileum, into the last 200 centimeter of the ileum. The disadvantage is that you're creating a blind loop of about 100 centimeter, and that is the disadvantage here. Again, a similar procedure is a sleeve gastrectomy with jejunal ileostomy, and sleeve gastrectomy with duodenal bypass. The concept again is the food is being transported directly into the to produce functional restriction. This one is an interesting procedure, the transit bipartition along with sleeve gastrectomy. Now the food is going from the sleeve gastrectomy to the normal passage, but there is another rulem of the distal ileum. So the food is also going directly into the ileum. So one passage is the normal passage. So there are 2 parts. One passage is the normal passage. So there is no malabsorption, but there is another food going into it. So this basically is a new procedure which is being done in both obese as well as non-obese patients. It has got promise. So 3 procedures have promises: the SEDI, the SASI, and this sleeve gastrectomy with transit bipartition. This is a similar procedures, so not that much, very much in fashion. So the idea behind this presentation was to give you an idea of functional restriction, and that functional restriction is based on the release of hormones by the distal ileum. So that functional restriction can be used in those patients in which, although they are not obese, but they have diabetes, and these metabolic procedures can be used in such patients who, despite of best medical treatment, are having uncontrolled issues. And we all know that there are certain disadvantages for those uncontrolled diabetes. So in summary, 2 mechanisms of weight loss after bariatric surgery. There's an anatomic restriction and malabsorption related to decrease in calories, but there are hormonal mechanisms which are independent of weight loss, and they decrease appetite due to suppression of ghrelin and produce better glucose homeostasis due to release of incretins like GLP-1 and GIP. They also produce early satiety due to release of PYY, oxyntomodulin, and glycine, leading to functional restriction, and hence can be used as a metabolic procedure for non-obese patients with medically uncontrolled diabetes. I thank you very much for your kind attention.